I've never really had to think much about point of care testing because I've worked in critical care environment for, as a consultant for coming up to 24 years now. And as a senior registrar, I was doing my elective in critical care medicine. So for well over a quarter of a century, sounds great, doesn't it? I've been working in the critical care environment. So most of the things that we wanted to know in terms of laboratory test results, it was always available. I never considered those things as point of care testing. So obviously, blood gases, the sort of thing that, the nurses are doing every few hours. And nowadays we have, all the main electrolytes. So there's virtually never a need to send blood to the laboratory to get those results. And much more importantly, we would have these results whenever we wanted. I don't think I ever thought of that as a point of care. I just thought that this was standard for an intensive care unit. And then glucose and blood coagulation, which has become much more of an issue or much more of an area of interest because I am principally a cardiac surgery, cardiac anesthetist and cardiac intensive care sort of clinician. And over the last, nearly 20 years or so, I've been taking a special interest in coagulation. And really, the laboratory doesn't provide me with much in the way of useful information about blood coagulation in a timely manner, at least. So I have been using sort of, if you like, point-of-care coagulation testing, which I'll, cover a little bit about in a moment. The one big area where in critical care there is point of care, but you probably will never discuss it, is point of care ultrasound. Now, point of care ultrasound in the critical care environment I would say, has revolutionized or should revolutionize patient assessment. For the best part of 10 years now, I've been telling medical students to throw away their stethoscope. It's a waste of time. You should learn point of care ultrasound. So if there's one use of the word point of care or one use of the phrase point of care in critical care, I think of it in terms of point of care ultrasound. And this is happening now increasingly, and hopefully, in a few years' time, this will be regarded as absolute standard of care, point of care, so that we don't have to send patients off for repeated number of X-rays and CT scans and so on, and we can make most of our assessments on point of care ultrasound. And stethoscopes should almost be never seen or found in an intensive care unit, probably in most of the hospital if I have my way. But of course, we're not going to discuss anything about point of care ultrasound in this meeting. Now, as I said, I met Tony at a meeting earlier this year, and this was sponsored by Werfen, and I don't want to divulge any sort of information. I hope Werfen won't mind, but I just mentioned that they'd asked me to chair a meeting about the future of point-of-care testing in critical care units. And what they did was they did a survey of critical care physicians from different parts of the world, and these clinicians proposed the sort of thing that they would like to see. So the angle I'm giving you is that you are very much involved in, delivering, managing point-of-care testing. But what I'm going to tell you is what I believe many critical care physicians are asking for, in terms of point of care testing, which may or may not be currently available at the moment. I'm just going to give you some examples of it, not really to go to them in any great detail. And I've broken them down into different areas, sort of metabolic. One is creatinine. Second thing is about hemostasis. And the third area, if you like, is about anticoagulation. And I'll just talk very, very briefly about these and tell you why, or suggest to you why these are candidates that we should consider providing as more of a point of care test, as opposed to something that you must send to the laboratory to get the information. Now, creatinine, as you know, it's really our principal indicator of renal function. Post-operative acute kidney injury is a very, very big thing in cardiac surgery. It's probably the the specialty of surgery with the highest incidence of post-operative AKI, probably about 25–30% of patients. And so while there is a lot of research interest going on in AKI, particularly post-operative AKI, most of that is focused on cardiac surgery because so many patients will get some degree of AKI after cardiac surgery. So it's a very good model to work on, rather than work on, AKI following some other types of surgery where AKI much less uncommon, much less common. Obviously, in the critical care unit, AKI is almost always seen in most of these critical states like sepsis, major hemorrhage, trauma, and so on and so forth. The area where the research is very intense is looking at novel biomarkers of AKI. These are interesting, but totally inaccessible to most of us because these are not tests that are something that you can request from the laboratory, in most places, unless you are actively doing research in that area. And so while that's very good, we are far, far away from getting these novel markers as a point of care, let alone in the laboratory as a routine test, let alone as a point of care test in the ICU. Now, why might you want to have either the novel markers or even creatinine as a point of care test? And a lot of people will say, well, it's pointless because creatinine is too non-specific for acute kidney injury. But nevertheless, the way we define acute kidney injury is by the change in creatinine. One of the things that people have perhaps never thought about is that the reason creatinine may not be very good as an early marker of acute kidney injury is that we don't do it very frequently. Most of the time, we get a creatinine result from the laboratory once every 24 hours. So if things are changing, when we've discovered it the next day, we don't know whether the change has happened a couple of hours ago before the blood test or 23 hours ago before the next blood test. And it occurred to me that maybe that is what we're missing here, is that we've always accepted that creatinine only needs to be tested in the laboratory, and because we only test for this once a day or once every other day, maybe that is a reason why we're not picking up acute kidney injury early enough. Maybe we don't even need to move towards these biomarkers, novel biomarkers, as interesting as they are. And there are about a dozen candidates, and not a single one of these, dozen or so candidates are so powerful that people have been sort of motivated to have those available as a routine test straight away. And the research on novel biomarkers for kidney injury has been going on for over a decade, and we are nowhere near selecting one that is going to be useful for every patient. So maybe we should go back to the old-fashioned creatinine and think about maybe having those results available more frequently. And so by having the results more frequently, let's say you were testing it like you would do a blood gas and you had the result every 4 or 6 hours, maybe you'll start to pick up some changes. And the reason why you want to know a bit earlier, well, again, that is a little bit controversial. Exactly the same thing as the argument for having novel biomarkers. The idea clinically is that if you knew that your patient was going into AKI, perhaps you could change your clinical management to mitigate so improve the resuscitation, improve the blood pressure, improve the cardiac output. So make some physiological changes in your physiological management of a patient, which might mitigate or perhaps even prevent the patient going into AKI. So that is a selling point for these biomarkers to detect AKI early. That early detection will allow you to intervene early. But have we looked at early changes in creatinine? We haven't. We haven't because by and large, we just assume that the laboratory gives us a creatinine value and it would be pointless to measure creatinine more than once a day or at the most twice a day. And so it's quite possible, in my view, that we have a potentially useful marker of AKI there, potentially early marker, but we're just not we don't realize it because we don't test it frequently enough. Yeah. So that is kind of my pitch for creatinine's point of care. Now, having visited some of the exhibitors upstairs, I know that there are point of care devices available that can measure creatinine. Okay, and for me anyway, I think it would be interesting to see creatinine as a point of care, perhaps as part of a blood gas panel. Because if nothing else, it'll give us a tool to now investigate whether it's actually useful or not. At the moment, we haven't done so. So just a couple of papers, that's a consensus meeting statement on the state of the novel biomarkers. That was 3 years ago. There's a worldwide interest in it, but if you look back at the history of research on biomarkers for AKI, as I said to you, it goes back over a decade. And while that sounds very good, consensus statement, blah, 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 but actually when you look at the detail of it, nobody can quite agree on which one is actually useful. They always propose a couple that are pretty good, but 2 years later, they'll propose something else that's pretty good. So I'm a little bit sort of skeptical about where we're going with that. The next paper is an interesting one, and this group said that, well, you don't need novel biomarkers if you use a form of AI, and if you if you analyze all the standard laboratory data that you can obtain from patients, you can work out whether somebody is going to go into AKI or not within 72 hours of the patient's hospital stay. And I kind of find that quite odd, really. I'm not quite sure what to make of it. It's wonderful, you use AI to analyze all your hundreds and thousands of data points, and you can predict who's going to go into AKI. But if I see my patients the following day after cardiac surgery, I can tell the majority of patients are going to go AKI the next day, simply by seeing the small change in creatinine. And certainly by 48 hours, I can predict the vast majority of my patients who are going to go into AKI, because you're using the patient as their own reference, and you can tell that. So this is why I'm suggesting that maybe we're missing something very useful here with creatinine. Now, just move on to a different topic now. In terms of blood, if you look at trauma in England and Wales, but this is pretty much the same for trauma in most urban settings. You've got very similar data from the Netherlands and Amsterdam. You've got very similar data from Houston in Texas. Okay, most deaths after major trauma are due to blunt trauma, and the second commonest cause of death after major trauma is bleeding. Okay, the commonest cause is traumatic brain injury, but the second commonest cause is bleeding. And this is data from, as I said, from England and Wales. Now, why am I presenting that? I'm presenting that because the management of bleeding forms a very, very big part of how we can make an impact into the outcome of these patients after major trauma. And this is where the relevance of the point of care coagulation testing comes in. Another area where bleeding is a significant contributor to morbidity and mortality is cardiac surgery. Cardiac surgery is the specialty of surgery that is associated with the greatest amount of blood product use, the greatest amount of bleeding. And to be honest, I do anesthesia for cardiac surgery. I do anesthesia for virtually all other types of surgery except pediatric surgery at the moment. And I can tell you that when I speak to surgeons in non-cardiac surgery and they start fretting about bleeding, I kind of look up and said, oh, okay, don't worry about it, you carry on. Because there's absolutely no bleeding in any type of non-cardiac surgery that comes anywhere near, I wouldn't say even anxiety level, in my experience compared to cardiac surgery. So why is bleeding such a major problem? Bleeding or excessive bleeding in cardiac surgery increases mortality, increases all the adverse outcomes that occur after, you can expect after cardiac surgery increased infection, increased AKI, okay? Obviously, as you know, if you've ever worked in cardiac sort of surgery centers, it means increased use of blood products, increased use of various drugs, prolonged hospital stay, and there's a major financial penalty, let alone the human cost of the patient effect of excessive bleeding in terms of morbidity and mortality. The only thing that goes down when you have excessive bleeding is the reputation of the clinician or the institution where they have the surgery. Now, sadly, with recent stuff in the news and talking about trusts wanting to protect their reputation and so on, this is very, very true. There is a major thing, and if there's one thing which may be a positive incentive for clinicians to improve the outcome of patients in terms of cardiac surgery is the fact that the clinician personally and the cardiac surgery unit's reputation will be blasted all over the newspapers as being, having associated with increased adverse outcomes, increased death. So in cardiac surgery in this country particularly, okay, clinicians make a very, very big effort to improve the patient's outcome, if no other reason than the fact that if not, the outcome is published. Cardiac surgery is the only surgery specialty in this country where the unit and the individual clinician's outcome is published publicly to be seen by anyone who's interested in seeing what goes on. So that is a really big motivator for people to make sure that they keep their outcomes as good as at least average. Now, what is the link between major bleeding in trauma and major bleeding in cardiac surgery? For me, the link is fibrinogen. Now, this is sort of, for me, very old news. I've been trying to preach this for 20 years. It's taken until about 5 years or so ago before in this country, clinicians have started to become much more aware, much more educated about the critical factor. Let me put it this way. For all the time that I was training until I became a consultant, the management of excessive bleeding and coagulopathy was dictated by what blood products are available in the lab and what was requested. So in other words, if your patient's bleeding a lot and they're potentially coagulopathic, you don't test for coagulopathy, you assume or you guess that there's coagulopathy. The next thing is you ask for fresh frozen plasma, because that's what everybody in the world does. If your patient is bleeding, you have red cells, you have fresh frozen plasma. And somehow you box and cox, and eventually the patient is managed appropriately or not, you've done your best. Okay, that's how it is. But it has become very evident 20 or more years ago, and possibly longer than that for some people, that the critical point, the critical factor in the blood that is missing or deficient when you start to bleed excessively is fibrinogen, okay? And we know that because we tested the blood for fibrinogen, not in the laboratory, but using a point-of-care viscoelastic testing. Now, once you start doing viscoelastic testing, you suddenly realize that, oh my God, all my assumptions about the reason behind this coagulopathic patient is not just partially wrong, but completely wrong. And the blood product I've been using 99% of the time to treat this patient is the wrong product, okay? So we can now say that for virtually all types of excessive bleeding, okay, in cardiac surgery it's the same, so trauma hemorrhage for perioperative bleeding, okay? The first clotting factor, if you like, to become deficient to a critically low level is fibrinogen. Now, if that is the case, the first thing that you should be doing is replacing fibrinogen. But for years, we have been replacing patients with very, very fibrinogen poor blood product, aka fresh frozen plasma. So in cardiac surgery, we know that fibrinogen concentration at the end of bypass or at the end of surgery is associated with postoperative bleeding. The same thing in trauma hemorrhage, where fibrinogen is the first to fall. It's first to fall in any kind of excessive bleeding, and the low fibrinogen is a predictor of death, as I said so there, okay? And what my own experience and the experience of lots of people over the last 20 years has shown is that the only thing that can very quickly show you whether fibrinogen is sufficient or not is point-of-care viscoelastic testing, and that will show you. And then what you need to do is replace fibrinogen. And in this country, it's either cryoprecipitate or fibrinogen concentrate. Now, we were the first major trauma center in the country, possibly in the world, to put down cryoprecipitate as the first-line replacement, not FFP. And we did that, well, how was our major trauma center? About 10 years old now. We did that more than 10 years ago. Before the London hospital, before anywhere in the USA, before anywhere in Australia, we were the first to put cryoprecipitate down. And people just thought we were mad. But fortunately, most of my colleagues had no interest in coagulation at all. So when I wrote the major trauma hemorrhage protocol, they just accepted it. And I had a very, very helpful collaborators in the transfusion lab who went along with this, and we provide. So, and we are also one of the first, if not the first, major trauma center in the country to provide fibrinogen concentrate as a first line. So we use that now instead of cryoprecipitate as the first line. Okay, just to show you that what you need to do is not to guess whether your patient has a coagulopathy or not, but to check and measure. And the next thing is to give what's needed. So think of viscoelastic testing as like a blood gas analyzer. I mean, no intensivist will go and see the patient and says, ooh, I guess the patient's CO2 is so much. I guess the patient's PO2 is so much. Or I guess the patient's creatinine is so much. Let's do this. Right? You say, well, just measure it and find out what the result is. Oh, creatinine is high, AKI, CO2 is high, increase of ventilation. So the viscoelastic testing is really a kind of a blood gas analyzer of coagulation, if you like, just objectively telling you what's wrong with the patient and what's needed. Now, the other thing, just to make the final point, is that while individual clinicians have been shouting about this fibrinogen for many years, and it was the Germans and the Austrians who started doing this back in the late 90s, early 2000s, across the world, international guidelines on management of bleeding has recognized this. And over the years, the threshold at which they recommend that you start replacing fibrinogen has gone up and gone up and gone up. When I was a trainee, there was no threshold. Later, it became 1 gram per liter. Less than 1 gram, you replace. Then it became less than 1.5, you replace. Currently, it's less than 2 grams you replace. Okay, so somehow the guidelines have sort of followed on from what some clinicians have known for a long, long time. Okay, so, these are just examples of viscoelastic testing. I'm not trying to promote them in any way. I have more than sort of 20 years experience of the ROTEM, but there's sort of like current TEG model as well. It doesn't probably matter too much which one you use. But the one thing I would say is that I know that some laboratories are a little bit, and many hematologists are very skeptical or very uncertain about viscoelastic testing because it's not part of their training, it's not part of their education, it's not part of their day-to-day management. But I tell you, the people that will tell you that this is the way forward are the people on the front line managing the patients, the surgeons standing there, giving the reassurance that I've just tested your blood, it's deficient in this, we're going to get this, and this is there, and that's fine. I can see the blood clotting now, okay? And those are the people that will tell you that they wouldn't, I mean, there was a period of time when our device went off the blink and we couldn't, it was some kind of bank holiday or something, we couldn't get it serviced or repaired. And the cardiac surgeon says, well, we're not going to operate. The ROTEM's not available, we're not going to operate. This is putting the patient at risk, So, I don't want to sound like I've got some kind of missionary zeal, but I have to say. So, as I said to you, I work quite closely with the lead biomedical scientist in transfusion, Julie Cole, and we've talked about this for many years now, and they have, I think, three Sigma devices now in the lab. If we could prevent any clinician from ordering any blood product apart from red cells, without a ROTEM being done first, we would save so much misuse and inappropriate use of blood products. A lot of people say, well, viscoelastic is a little bit difficult to understand, it's very complicated. And so one of the things, we thought of at this meeting was maybe what we need is a point of care test of fibrinogen, because that's absolutely key. If you gave me no other information other than fibrinogen, I could probably manage 80% of the time. And maybe we don't need all this complicated, tag tracing and stuff like that. And all we need is really just point of care fibrinogen. And certainly, you could say that before you order any blood products, you should at least check a fibrinogen very quickly. And if the fibrinogen is low and your patient is bleeding, you should say to the clinician, maybe you should get some fibrinogen first, and then we'll give you the other bits later on, once your patient is still not better, okay? There are many areas, not just in cardiac surgery, where you could benefit. Now, if you're in Wales, you're very lucky because every Welsh maternity unit has a ROTEM device, and they've had that for quite a few years now. And the Welsh, I guess it's the hematology, stroke, obstetric, anaesthetists, obstetricians have really pushed forward the understanding and the management of obstetric bleeding in this country. Okay, and that's largely come from a couple of individuals, but also the fact that they've got a ROTEM in every delivery unit in Wales. Yeah, all types of hemorrhage, emergency department, non-cardiac surgery would benefit. Obviously, a major trauma center in this day and age, if you don't understand fibrinogen, you have to ask, what do you understand? Interestingly, obstetric hemorrhage, for the most part, it's not associated with low fibrinogen because pregnant women, their fibrinogen doubles during pregnancy. Okay, let's just move quickly on to platelet function, platelet count, because platelets are obviously two things. One is the number, the other one's the function. And the count is important insofar as we know physiologically you need platelets to clot. However, it's been clearly shown, and this is supported by guidelines, that unless your platelet count is very low, you can just press on and have surgery without having to transfuse platelets. And in fact, generally speaking, you don't need to transfuse platelets unless the platelet count is very, very low. Okay, in cardiac surgery, platelet count is important to some extent, and certainly there is some data that shows that if your preoperative platelet count was low, then you've got increased adverse outcomes. So it's a bit like kind of a double-edged sword, really. You can go ahead with surgery despite lowish platelet count, you don't have to transfuse. But then again, if you have a lowish platelet count, at least in cardiac surgery, we know that it's associated with the worst outcomes. So, what does that mean? Should you be more proactive with the platelet transfusion? Should you not? And there's been a debate for many years about whether platelet transfusion are ultimately safe or unsafe in terms of the effect of transfusion. So one of the things that I thought might be useful is, again, platelet count, a bit like creatinine. It's sort of something you ask for when you had a full blood count, and you won't necessarily ask for a full blood count 4 times a day. And so maybe if we had a point of care test of platelet count in some areas, such as cardiac surgery, we would have some kind of tool to investigate whether transfusion of platelets, is useful or not. Because if your patient was bleeding and oozing for many hours, that's not good for the patient. But if you give platelet transfusion and stop that bleeding, maybe that is ultimately more beneficial for the patients than potential risk of platelet transfusion. We don't really know. Nowadays, platelet function is a big issue because of antiplatelet drugs. As you know, many patients are on antiplatelet drugs now for any kind of cardiovascular disease, stroke, cardiac surgery, so on and so forth. In cardiac surgery, of course, we have the problem where patients come for surgery who are already on antiplatelet agents, so they increase likely of bleeding. And in other types of surgery, they have a similar kind of problem. So understanding platelet function, as opposed to just a platelet number, has been very important. And that's an area that we've been doing point-of-care platelet function tests for nearly 20 years, well, about 20 years now. And we're one of the very few centers in the country, even in cardiac surgery, where we do platelet function testing. Many cardiac surgery units don't actually offer platelet function testing, and we've been doing it for 20 years now. We also provide a sort of an informal service to the neuroradiologists who want to know whether the antiplatelet agents are working before they put a stent in. We provide an informal service to the stroke physicians who want to know whether the antiplatelet agents are working, if the patient's had a recurrent stroke, for example. So we do a lot of informal service. And in Brighton, we're the only people that do platelet function testing. So the lab doesn't offer it at all. And so it's a little bit kind of like irregular, if you like, the arrangement. But it started off as a research thing, and we now provide the service for cardiac surgery, cardiology, as I said, and for the other agents, other specialties. Now, is it useful? I think it's useful in specialist areas, possibly, but my colleagues in the non-cardiac surgery unit have a device that gives them a sort of platelet function as well, not multiplate or verify now, but a different device, which is perhaps not as good as the multiplate. And they certainly use it quite a lot because they do a lot of vascular surgery and a lot of patients are on antiplatelet agents. So we've been using the multiplate for nearly 20 years, and we use this briefly, but we don't use it at the moment. It's much more expensive, the cartridge. Okay, anyway, a couple of other areas. There was some talk about point of care testing for DOAC. As you know, direct oral anticoagulants are widely used now for prophylaxis and atrial fibrillation, and lots of other sort of indications given there, prophylaxis for DVT, treatment of various situations. The good thing about the DOAC, the reason they were such a fantastic sort of new drug compared to the historical warfarin was that you don't have to test whether it works or not. And so the manufacturers had no interest at all in developing a test to test it. Because if they develop a test to test it, test the level, then they'll be saying, well, this is not a very good drug. The whole selling point about DOACs was that you just give it and you know it works. You don't have to test it. But then people started getting worried, saying, well, what if somebody turned up in a car accident and they were bleeding to death? And we didn't realize that they were bleeding to death because they're taking a DOAC, right? And so we would want to know whether there is any significant level of DOAC in the patient or not. And then the manufacturer then started to say, oh gosh, we better invent an antagonist for the DOAC, to stop them bleeding to death if they're taking it when they've had a car accident or something. So it's become very, very complicated now about, well, is there any point of testing? Should you just, treat them with, something, just assuming that they're taking it? And so a lot of clinicians, particularly ED clinicians, were very keen that somebody develops a point of care device that would test the level of DOAC to see whether it was high enough to be contributing to excessive bleeding or a patient not clotting, for example. Okay, so this cry for a point of care test was coming particularly from ED doctors, because they said we have a real problem with patients coming in who is or who might be on a DOAC, who may have a problem, and so this is not an area that I get too much involved with in cardiac surgery, because generally speaking, if a patient comes in for, say, an aortic dissection and you have no choice but just get on with it, and you knew that they were just taking a DOAC, then you just have to deal with it. There's no point saying, oh, let's test the DOAC level. Oh, that's a bit high. Oh, let's postpone the operation for 48 hours. You can't do that. So in my area of work, that's not a big issue. But in emergency medicine, they argue that they really could do with a point-of-care test for DOAC concentration. This is a bit specialized. There was a lot of anti-10A levels was being measured, on every single patient twice a day, every day, and during COVID. And I'm not really sure how important it is, but in a very few number of cases in cardiac surgery where there may be heparin resistance, we might use it to monitor heparin and to monitor the adequacy of anticoagulation. And that in some sort of niche areas, There's also some requests for anti-10A level. At the moment, anti-10A level is not necessarily available in every hospital, as far as I understand. And even when it's available, most places, it takes 2 or 3 hours to get the result. So in some of these very niche area, what you need is not just anti-10A level, but something that you can get a result within 10 or 15 minutes. Okay, and obviously, are we ever going to get there? Is this ever going to be provided? I don't really know. Okay, so really, in summary, then, I think there are a number of currently laboratory-based tests that one might consider rolling out as a point of care. So just creatinine is just sort of one example. Okay. Having said that, we don't have a lot of evidence. So if I said to you, roll out that point of care creatinine test, make it available in every blood gas device, and you said to me, what's the evidence that this is going to benefit the patients or whatever? I'd say, well, there is none. And if I've looked in the literature, there's absolutely no evidence to push you one way or the other to do any of these tests. Yeah? But I'm just sort of giving you my perspective. There are some point of care technologies that are, at the moment, which are used in semi-specialist areas that I really, really believe would benefit patients if we roll it out more, such as the viscoelastic testing, for example. Okay, as I said to you, every maternity unit in Wales has a Rotan device, and I can tell you that has transformed the management of obstetric bleeding patient in Wales. Yeah, why Wales? I don't know, but there was 1 or 2 people that were very keen on it, had an interest in it. They talked to the company, and they did a trial. And I think that is the way forward. You know, if it was me, every hospital in this country, every hospital that supplies blood products should have a viscoelastic testing device to test. That's my personal view. Yeah. Okay. In fact, I was at a meeting in one of the meetings in intensive care many years ago, about 10 or 15 years ago, and this intensivist from Swansea asked me, Robert, outside a cardiac surgery center, do you think that every hospital should have a Rotan device? I said Rotan at the time. I said, no. I said, I think it should be only in specialist center. I'm completely wrong. I'm completely wrong about that. I wish I hadn't said that now. He's absolutely right. Every hospital that provides blood products should have a viscoelastic testing device. Yeah. Point of care fibrinogen monitoring may be a simple alternative, and certainly anybody who's bleeding, you must get the fibrinogen concentration, and people must be responding to that first and foremost before anything else. Okay, I'll leave it there. I hope that was useful to you, and by all means, please ask questions if you have issues that, you know, or anything that you might not agree with. Please say so. Thank you very much.